So our next speaker is Dr. Ritika Goel, a family physician with the Inner City Health Associates and a health justice advocate. Ritika completed medical school at McMaster University, family medicine residency at St. Mike's Hospital at U of T, and a master's of public health at Johns Hopkins. Her clinical work focuses on people experiencing homelessness as well as migrants without health insurance. She's a volunteer physician and board member of the Scarborough Community Volunteer Clinic for the Uninsured and co-chair of the Ontario College of Family Physicians Poverty and Health Committee. Welcome.
Thanks so much for having me. I'm glad you can actually see me over this podium. It's sometimes hard. Okay, so we're here to talk about politics, policy, and marginalization, and I had some trouble figuring out really where to focus because there's so much. This is such a rich topic. There's so much to talk about. As a family physician, I've been privileged to work with many people who've experienced a great suffering in their life, who've chosen to put their trust in me and share their hardships, and I can't help but notice no matter how unique different experiences of marginalization are, there are always threads that run through connecting these stories. Whether we're working with people experiencing homelessness, those with mental illness or using substances, racialized migrant men, women, and children, Indigenous people, sex working women and men, individuals who've experienced long incarcerations, abusive relationships, the thread that ties them all together is trauma. And I don't just mean the individual trauma that they've experienced in their lives, although that is great, but I also mean the collective trauma that society continues to inflict on them on the daily. And that's really how politics and policy play out. Politics and policy, unfortunately, as you've just heard, and a great example of, rather than addressing the marginalization of these groups, is actually creating the very systems that reinforce it. So how do our current public policies stack up in terms of serving the health of marginalized populations? Well, we're in a position now where the top 1% of the world has about as much wealth as the bottom 99% put together. And in Canada, the top 10% own about 50% of the wealth, while the bottom 50% have only about 6%. And yet, when you look at policy, Canada also has the lowest corporate tax rates in the entire G8. 2014, in fact, was the first year that more than half of federal government revenues came from personal income taxes instead of corporate. And with our new federal government, we really have yet to see any major changes in this. At the same time, wages have stagnated. Working a full-time job at the minimum wage still leaves you about 16% below the poverty line in Ontario. And the most recent increase in the minimum wage in Ontario was about 25 cents. And if you're without work, in Ontario, currently a single person on social assistance gets $681 a month. If you compare this to where we were in 1993, in absolute numbers, it's almost the exact same amount. But in terms of inflation, in 1993, people were receiving about $1,000 in today's money. So we're actually giving way less in social assistance today than we were back in 1993. And that's because in terms of policy, we've never recovered from the cuts under the Mike Harris government. And in fact, even the 1993 levels were 20% below the poverty line. So where are the policy levers here? Well, again, the most recent increase that we've seen to the welfare rate is $25 a month. We also have 4% of the Canadian population that identifies as Aboriginal, but 23% of our prison population that identifies as Aboriginal, with Aboriginal women being even more overrepresented than men. Similarly, Black people make up about 2.5% of Canada's population, but over 9% of the federal prison population. And unfortunately, if all of us were to walk out of this conference today, those of us in this room that are Black would be 3 times more likely to be carded by Peel Police, which is the stats in this region, than those of us who are white. Over 95,000 households are on the waiting list for subsidized housing, with waits being up to 7 to 8 years long. And our federal government, while it has given us a proposal for investment in housing, it really still hasn't put forward a plan for a national housing strategy plan, which is what many high-income countries have. We also have an immigration system, which you heard a bit about, that has made it harder and harder to obtain permanent immigration status and much easier to lose it. Our idea of a childcare system is to bring young women from the Philippines to take care of our children while they leave their own at home, and then provide multiple barriers to them obtaining a path to citizenship that lets them end this limbo and bring their families here. We've also had, since the year 2000, 14 deaths in our immigration detention system. Many of these have been suicides. And meanwhile, our healthcare system continues to deny health coverage to an estimated 500,000 people in Canada because of their immigration status. That could be new immigrants waiting 3 months in Ontario, BC, and Quebec to access health insurance. It can be temporary workers between contracts, international students, people awaiting different types of applications, undocumented people, and even returning Canadian citizens. And while all of this occurs, our planet continues to literally burn. While no one climate event can ever be directly causally linked to climate change, we know that it's precisely climate change that has created the conditions for the tragic fire that's taking place in Fort McMurray. And we also know that climate change is likely to impact those most vulnerable, whether that's people experiencing homelessness, living in overcrowded conditions, those living in lowland areas that are more prone to floods because they can't afford the real estate that's in higher areas, or those that are reliant on subsistence farming, which is impacted by unprecedented droughts. Unfortunately, in this realm, too, the proposed policy changes at both federal and province levels really just tinker around the edges. So firstly, I think we can all agree that all of what I've talked about are not just exercises in exploration of policy and politics, but really they're about health. But secondly, in order to improve the health of our communities, particularly those most marginalized among them, I would argue that what we need to do is engage in politics and policy. Because in fact, at the end of the day, it's actually politics that is our number one determinant of health. And now, while I've raised many convergent crises, the reality is that in every single one of these realms, we've also in the past 5 years seen incredible movements. So it's not all that grim. We've seen Occupy Wall Street, which has given us the language of the 1% and the 99%, and has forever changed the conversation on income inequality. We've seen Idle No More, which started right here in Canada and then became a worldwide movement demanding the rights of Indigenous people. Most recently, we've had the historic Truth and Reconciliation Commission, which you'll hear more about. And just a few weeks ago, there was an occupation of the Indigenous and Northern Affairs Canada office here in Toronto in response to a rash of suicides in Attawapiskat at James Bay. We've also, particularly in this city, seen Black Lives Matter completely change the conversation on race and police brutality. In Ontario, the Workers' Action Centre has been mobilizing for they've been mobilizing actual low-wage precarious workers, many of whom work at the airport right nearby us, and pushing for an increase in the minimum wage as well as the fight for decent work, and calling for access to paid sick leave for all workers. We've also seen, as you've just heard, the reversal of the cruel and unusual refugee health cuts imposed by the Canadian government, and you'll soon see the launch of a new campaign called OHIP for All, calling for access to healthcare for all people in Ontario regardless of their immigration status. And finally, on the biggest question of all, we've seen a conversation around the LEAP Manifesto, which is based on research that Canada could get 100% of its electricity from renewable resources within 2 decades, and by 2050 we could have a 100% clean economy that's free of fossil fuels. So there is hope, and I think the hope really exists when we all come together. And we as healthcare providers, health researchers, health workers have a particular role to play. At the practice level, there's much that we can do to address our unconscious biases in our direct clinical work so that we don't end up reinforcing and perpetuating the systems of racism, sexism, ableism, homophobia, transphobia, and discrimination against people experiencing homelessness and poverty that are already out there. We unfortunately know that these factors do influence the direct care that patients get in our healthcare system, aside from also being social determinants of their health. There was a study done in Western Pennsylvania that brought together 33 doctors and had them interact with standardized patients, and they didn't tell them what the study was about. In the end, the study showed that when interacting with white patients, the doctors were much more likely to stand close to the patient and to touch the patient. Whereas when interacting with Black patients, they were much more likely to stand far and to keep their hands occupied holding a binder. These are subtle messages and subtle differences, but they really do impact people's care. There was also a study that showed that women are much less likely to receive pain medication in a timely fashion in the emergency room, and similarly, people of Latino and Black backgrounds are less likely, they're also less likely to be believed in terms of the level of pain that they report having. So there's much that we can do, being actively aware of our own biases and working to understand the experience of our patients, especially experiences that we're not familiar with ourselves. And the reality is that we have inherent blind spots. All of us have blind spots about an experience that's not our own. So it means listening to the lived experiences of people, understanding that we may carry an invisible knapsack of privilege that we're not aware of, and that also this isn't about cultural competency, which is just about learning the culture, someone else's culture, which is a different culture, an other culture, as opposed to actually practicing anti-oppression, which is about realizing everybody's rights and the need for justice. So part of that means looking at ourselves, right? This privilege that we have as healthcare workers, researchers, providers, comes with great responsibility, and there's much that we can do. That can come through using our own research to look at questions that are often not answered. It can mean coming through, looking at these issues through a health lens, which, as you can see, can be really powerful in terms of changing policy. And it can mean through direct advocacy work. We saw great examples of this already. So writing op-eds, signing open letters, signing petitions, organizing public events like this one to have this conversation, and yes, even occupying government offices and going to protests and doing all of that stuff. But in doing this advocacy, we have to learn how best we are supporting the communities that are directly affected. We have to be careful that at the end this doesn't become about us. This is still about the people that are directly affected. And it means amplifying the voices of people who are not traditionally heard and adding our voices when it's appropriate to do so in the way that is appropriate. And there's lots of great examples of this work happening. We've seen in Toronto and Ottawa, research on the efficacy of safe injection sites has now actually led to a place where, after years and years of conversation, we're finally looking at piloting supervised injection services in the city. We've also seen years of research and advocacy work from both the community and the health sector around pushing for a universal pharmacare program. And finally, we're starting to see these conversations enter the halls of power at the highest levels, and perhaps national pharmacare will actually become a reality. And as I mentioned, the Workers' Action Center's great work around the minimum wage campaign. Most recently, there was a lot of work done to push for paid sick days, and healthcare workers got involved with this. We had an open letter that was signed by almost 1,000 healthcare workers across Ontario calling for access to paid sick leave for everybody in Ontario, and we're very hopeful that that's going to get passed as well. So when we organize, when we mobilize, when we get involved, and when we truly look upstream to think about how we can impact the policies and politics that determine the health of our populations, I think that's when we start to have the most effect. And that's where I know I plan to put my energy. I hope you'll join me.